Thanks everyone for joining again. This week we will have Dr. Hsieh from CHLA, who's a double-boarded pediatric intensivist and pediatric cardiologist who will be talking to us about quantitative methods in cardiac ultrasound. This is an important aspect of what we do in terms of really being able to provide data that helps us with making echo across different patients make the same sense. So, Anne, thank you so much for talking, and take it away.
Okay, thanks, Eric. So yeah, I'm Anne Hsieh, and I'm one of the cardiac intensivists at CHLA. So this is a pretty large and relatively complex topic in ultrasound, but this is really meant to be an introduction to some of the quantitative methods that we can use in cardiac POCUS. So I don't have any disclosures, but my disclaimer is that I am cardiology trained and in critical care. And so a lot of these concepts and quantitative methods that I've learned are from echo and from my cardiology training and not necessarily POCUS. And so if there are, things that maybe Eric, you can point out where are either impractical in POCUS or things that we commonly use more often, then feel free to do so. Oh, sorry, here, let me use my mouse. This is the outline of what I wanted to talk about. So I'll start off with an introduction. I'm unfortunately going to have to do a lot of physics and review hemodynamic measurements. I'm going to mostly skip over evaluation of systolic function because you have either just gotten this lecture or will get this lecture in the LV and RV. And then I'm going to briefly review the evaluation of diastolic function. So this is kind of an overview of POCUS and how it has evolved over the last decade. Over time, there's been a lot of advances in technology and have allowed for more portable and intelligent devices. And so for good reason, POCUS often focuses on qualitative measures because we're trying to do quick assessments for rapid decision-making, such as cardiac function. But the use of quantitative measures has really started to grow, especially in the adult world, in the emergency department and in the ICUs. Since 2018, adult critical care doctors have been able to be certified in advanced critical care echo. And so they do test on these measures. And then the other thing I would point out is that over the past couple of years, there's been a lot more AI, which uses quantitative measures. And so understanding how these are obtained and how they are done and the physics behind it can help us review those and understand what those limitations are. So the next few slides, I just wanted to go over some examples of POCUS where I think qualitatively we are able to see what is abnormal, but then also to understand what the limitations are in just using an eyeball method. So in this example, you have your 4-chamber view, and you can see that the right part is enlarged. In pediatrics and in less obvious cases, it may be hard to tell if the right side is truly enlarged or if your left side is hypoplastic. And so using quantitative measures and comparing them based on age and size and Z-scores, you may be able to differentiate between the two. And then the other thing I would say is that if you are doing serial ultrasounds, you may be able to also follow changes in dilation or hypertrophy. For function, I think a lot of us looking at this would say that this patient has overall decreased LV function, and you could probably call this severely depressed function. And studies have shown that just by eyeballing, with POCUS, we can actually evaluate LV systolic function with some reasonable accuracy. But there are definitely limitations, and there's it's prone to inter-observer and study variability. And so this also relies on the skill of the interpreter. And so quantitative measures, we can use ejection fractions and things like that to more accurately determine what the function is. And then I would say that another study also, one large study on cardiac POCUS was looking at misdiagnoses, and kind of borderline systolic dysfunction was one of those named. The other thing is valvulopathy. So on the left in your peristernal long axis view, you can see that the aortic valve is really thick. It's not opening very well. You have aortic stenosis. On the right with color Doppler, you are able to see mitral valve regurgitation. So these are very useful things that we can do with POCUS qualitatively, but then quantitatively, we can determine what that gradient is across that valve, or we can determine how we can grade the regurgitation and then use those in serial measurements. So when we talk about quantitative methods, I broke it down into basically structural measurements, which we adjust for growth, and then hemodynamic measurements, which will be the bulk of this talk. So structural measurements, this is probably the simplest quantitative measurement we have in cardiac ultrasound. We can look at linear dimensions, we can look at volumetric dimensions, and then like I mentioned, for pediatrics, we really have to adjust for growth, and oftentimes that's with a Z-score based on their BSA. Key imaging techniques, you want to make sure you perform these in multiple views if you're able to, just to get more accuracy. And then in pediatrics, which I think is different from some of the adult literature and older literature, is that we measure inner edge to inner edge. And you do want your vascular diameters to be perpendicular. And then for valvar and vascular diameters, you want to measure those at the max expansion. So for example, the IVC is going to be during exhalation, and for AV valves, that will be in diastole. I'm not going to go through all the different ways to measure all the different structures. So I just wanted to direct you to this article, which is a really comprehensive review and a great reference for those quantitative measures of different structures and how you can measure them. I would say that LV cavity is probably the most commonly measured structure in cardiac POCUS, though. So I did want to just really quickly go over how we do this and how it's different in adults. The image on the left is your peristernal short. And so you're trying to measure your LV and diastolic dimension in that view at the maximum dilation, which is usually at the area of the papillary muscles. In adults, they tend to do this in the peristernal long axis view. And so that is because for adults, the structure of the LV tends to get a little bit more obscured when you use the short axis view. I'm going to just quickly go over this because I know you're going to get this in another lecture as well, but the other really common quantitative measure we can do is LV cavity dimensions with the Simpson biplane method. And so you are doing this in both the apical 4-chamber and the apical 2-chamber views, and you're tracing the LV cavity at end diastole, which is that bottom picture, or in end systole. And so I think I flipped those around, the end diastole and end systole. And then you're trying to calculate the difference using the computer programming. They basically sum the discs together and then come up with a volume. And so that ejection fraction is based on the difference between those two. And there are limitations, again, to this, because you want to make sure you have a good view. You want to make sure that you're not foreshortened. And then this is not always going to be accurate if you do have valvular insufficiency, like mitral insufficiency or aortic insufficiency. Another less commonly used method for measuring LV volume is going to be the area length method, but this might be simpler. So if perhaps you're short on time and you can't do all of the measurements of the Simpson, you can do the cross-sectional area of the LV and multiply that by length and 5/6. So going into more of the hemodynamic measurements, Doppler effect is used to assess the velocity and direction of blood flow. So sound waves that hit an object moving towards the sound source are going to be reflected with higher frequency than sound waves emitted from the sound source, which is that top figure. And that leads to a positive frequency shift. On the other hand, if you have an object going away from the sound source, then the reflected waves are going to have a lower frequency than the sound waves emitted from the sound source, which is that bottom one, and that will lead to a negative frequency shift. And the example, this is like a whistling train that's passing a standing observer, where you notice that the pitch is going to be higher when the train approaches than when it's moving away from you. This is the Doppler equation, and I'll just point out a few things here. So the Doppler shift then is going to be the difference between the difference in frequency between the emitted and the reflected sound waves. And so if you rearrange this equation, you can see that the Doppler frequency shift is going to depend on the velocity of blood flow, the speed of sound in soft tissue, the transducer frequency, and your Doppler angle. And so your Doppler angle is going to be important when you're scanning, because if you have an angle of 0 degrees where you're perfectly parallel, and this is the optimal angle, then you are going to have the max Doppler shift. Whereas if you if you're perpendicular to what you're trying to scan, then you're not going to have any Doppler shift. And so that's going to be really inaccurate. And in practice, this means that angles up to 15 to 20 degrees are generally acceptable, but anything beyond that is going to really lead to an underestimation and a miscalculation. Another review of spectral Doppler is there's pulse wave Doppler, and then there's continuous wave Doppler. The pulse wave is you have short bursts of ultrasound waves that are sent and analyzed by the same transducer element. And so that means because you're using the same transducer element, the max velocity that can be measured is going to be reduced. This is good if you're trying to analyze a small area at a specified depth, but you're going to be inaccurate with high velocity signals. Areas where we use this are going to be mitral valve inflow, which we use in evaluating diastolic dysfunction, and also with tamponade physiology, and then also for the LVOT. And then your continuous wave Doppler, you have continuous emission and analysis of ultrasound waves. It uses 2 piezoelectric crystals, one that's going to send the ultrasound waves out and the other that analyzes reflected sound waves continuously. So this allows for analysis of higher velocities, and then you can also record velocities along an entire path of the beam, but it means that you aren't going to get a specific location. And so we use this with TR, tricuspid regurgitation, and with valve stenosis. One of the problems with pulse wave Doppler is that, like we mentioned, if you're at a high velocity, you're going to be limited because of this concept of the Nyquist limit and aliasing. So pulse repetition frequency is the number of ultrasound pulses that are sent over a specific time. And the Nyquist limit is going to be that number divided by 2, which is your maximum velocity that can be determined. Aliasing occurs when your velocity exceeds that max velocity. And what that looks like on ultrasound is that you go beyond this screen and you have the signal wrap around your baseline. For color flow Doppler, it's typically the red flow is going to be towards the transducer and blue flow is away from the transducer. And the color hues are going to get brighter as blood velocity increases. So we do often use color Doppler to measure things qualitatively. We want to look at flows and velocities, and it may show some turbulent flow, but we can also use this quantitatively, which I'll go over later on in this talk. And then it can also help you align your continuous Doppler where you want to put that signal. It is also limited by the Nyquist limit, even more so than your pulse wave Doppler. And so if your velocity exceeds this Nyquist limit, then aliasing is going to occur. And that means the signal changes color. So the blue becomes red and the red becomes blue. For tissue Doppler imaging, this is now, instead of looking at Doppler for blood flow, we're looking at myocardial motion with the Doppler effect. And so this is going to capture high amplitude and low Doppler shifts. And again, we will go over some of the ways we use this for quantitative measures. So we're going to go over now review of hemodynamics, which is the study of blood flow dynamics. And we'll start with stroke volume and cardiac output, which in order to understand that, you have to understand how we calculate velocity time integrals. So when we look at volume that passes a specific segment, that is usually flow times time. But that assumes that your flow is constant, which is not the case in the heart, right? So in systole, you have really high flow, whereas in diastole, you have almost none. And so these pronounced variations in flow throughout each phase, where you're rapidly accelerating flow in early systole, and then you have decelerating flow in late systole and nothing in diastole, can be captured with Doppler and with velocity time integral. The VTI is basically this area within the spectral curve that indicates how far blood travels during that flow period. And for this example, where you're trying to look at your VTI across your aortic valve, you're going to put your Doppler at the valve, at the level of the valve in your 5-chamber view. So then stroke volume can be calculated by this VTI times your area across the valve orifice. And then cardiac output can be determined by stroke volume times the heart rate. And I would say that this is not actually a standard calculation that I've seen commonly done in pediatric echo, but I do know that adult cardiac POCUS uses this a lot. And I think one of the reasons that we don't as much in pediatrics is because of the room for error. So because your area across your orifice is going to be determined by pi r squared, that means any inaccurate measure of your diameter is going to be squared. And so that error ends up being squared. The other thing is we typically only use this across the aortic valve because you can get a pretty much parallel, you can be parallel with the blood flow across the aortic valve, whereas some other valves like your pulmonary valve you may not have that accuracy. And so your VTI calculation is not going to be accurate, which then leads to a lot of error. The relationship between pressure and flow can be captured by the Bernoulli's equation or the conservation of energy principle. And this basically is one of the most common hemodynamic principles we use by ultrasound, because we use it to estimate the pressure difference between two anatomic locations. So in this figure, you can see that the more narrow section is going to be P2 and the more proximal open area is P1. And pressure is a form of potential energy that can be converted to kinetic energy in the form of flow. So the Bernoulli equation, or this principle, states that energy at all points within a closed system must be constant. You can't create it or destroy it, and it must be transferred from one form to another. If your measurements are at 2 points are close to the same height, then the gravitational components are assumed equal, and you can simplify it to the equation on the right, which I think is what we're more familiar with. The limitations of this simplified equation, though, does not account for the pulsatile flow in the cardiovascular system. So this is where your complete Bernoulli equation comes in. And this might seem overwhelming, but it's really just pointing out that there are three energy components to the Bernoulli equation. You have your kinetic component, your inertial component, and your shear stress component. And so the kinetic one is what we are all most familiar with. This is measuring the increase in velocity from point A to point B. And this is what's going to be most important when you're looking at stenotic orifices. If you have a really large pressure difference, then V1 is generally small and can be ignored, and that simplifies your equation even more to what we're used to. The next one is local acceleration, or the inertial component. And this is seen when you don't have obstruction. So if you were trying to measure an area without any obstruction, like the LV inflow or outflow tracts, then this inertial component is going to dominate your energy. And so you can't really use your simplified Bernoulli equation. This is ignored in areas of obstruction because we're more interested in looking at the mean and peak pressure differences. And then the final one is going to be shear stress components. And this is going to be important if you have really smaller stenotic vessels. In the cardiac ICU, where we're taking care of our post-op Norwoods or stage 1s, and we're trying to get a gradient across the BTT shunt, it's not going to be very accurate with the simplified Bernoulli because of this reason, because we have shear stress. However, across valves, this is negligible, and so we can just ignore it. And so typically when we're just talking about obstruction across the valves, we can use a simplified equation. The half density is just converting that unit to units of millimeters mercury. And so that's where you get that number 4 from when we do the calculation by ultrasound. So for blood flow evaluation, we can look at changes in volume of a chamber, or we can look at flow velocity and the cross-sectional area of flow. And so it's important to look at flow profiles, which are basically made up by different velocities across a flow stream. This diagram is to basically show you differences in flow profiles in normal pulsatile blood flow throughout the cardiac cycle in different vessels. So their blood flow velocity is going to be influenced by various things, including the size of that vessel, the shape of the vessel, the wall characteristics, your flow rate, the phase of the cardiac cycle, and blood viscosity. And the figure on the top is showing you what that looks like in a straight rigid tube, where proximal or at the inlet, you have a nearly flat velocity profile, where as you progress more along the vessel, it becomes more parabolic. And so you have zero velocity near the wall, and the highest velocity is going to be in the center of that vessel. The bottom right figure is showing you flow profiles at vascular bifurcations, such as your carotid artery bifurcation. And so you have greater central velocity in the carotid artery that results in a skewed velocity profile in your internal carotid artery, with greater velocity flow along the aspect of the vessel adjacent to the bifurcation. The Doppler flow quantification is essentially looking then at stroke volume, which we already mentioned, where you're measuring the stroke distance or your velocity time integral and multiplying that by your cross-sectional area. Because the vasculature is a closed system, we can use this principle of conservation of mass to predict flow at various points in the circulation. So basically, what goes in must come out. And as we review flow through stenotic orifices and even regurgitant flows, you can see where we can apply this. In the absence of any intracardiac shunts or any valve regurgitation, the flow across all 4 cardiac valves must be equal. And in this example, you can see that with the mitral valve and the aortic valve. So taking a deeper dive into flow through a stenotic orifice, if you look at the flow patterns across a valve, you can see that there are different areas of flow. And so at the top, you have this flow convergence zone, which is characterized by non-turbulent flow that follows streamlines converging into a symmetric pattern. And this narrows at the point beyond the anatomical orifice area, which is known as the effective orifice area or your vena contracta. Beyond that, the streamlines then diverge in the jet laminar core. And around that, you have these little eddies known as a parajet turbulent flow area. And so it's going to be important to understand these flow patterns, to understand the limitations of what we can assess across a stenotic orifice. So there's this coefficient of contraction that basically represents this magnitude of flow stream compression, which is defined by this effective orifice area or your vena contracta divided by your anatomic orifice area. This is what is going to deter your effective orifice area is going to be more important in determining your the hemodynamics of a stenotic area. The table on so with the figure, you can see on the left, you have a relatively flat orifice, and that's comparing it to a circular orifice on the right side, but with a conal inlet. And so because the direction of flow and the lateral streamlines are less angulated relative to the central axis of flow, the conical inlet example actually results in less flow contraction at the level of the vena contracta. You can see that it's a little bit wider than the example on the left where you have a flat orifice. The table on the right just emphasizes this a little bit more, where while your coefficient of contracta is dependent on your anatomic area, it's actually going to be even more dependent on what your inlet geometry looks like, where the flatter valve shape is associated with a more marked contraction at the level of the vena contracta. Another thing that we have to take into account when we're looking at flow through a stenotic orifice is this concept of pressure recovery. So the figure on the left, that top, is basically your LVOT. The V is the LVOT, your valve is your aortic valve, VC is your vena contracta, and A is your ascending aorta. And the bottom corresponds to changes in pressure and total energy as you move through this vessel. So initially, kinetic energy is small and static pressure dominates. And as the flow accelerates through the valve or across the valve, your static pressure is going to reach a minimum value at the vena contracta and then rise to a final level, which is labeled as the delta P net there, that is below the initial level. Your then distal to your vena contracta, your parajet turbulence flow results in loss of kinetic energy that is not fully compensated by the pressure recovery time. And so there is a net loss of energy. When the blood flows across a stenotic orifice, velocity is going to rise and pressure is going to fall. And so that lowest point, the lowest pressure point is going to be the narrowest portion, which is the vena contracta. As your stream widens again, this flow velocity diminishes and the pressure rises, which is what is known as your pressure recovery time. The figure on the right is a Venturi tube, and this is a cylindrical pipe that has streamlined constriction that is really designed to minimize any energy losses. So this is optimized to eliminate that parajet stagnant area. But basically for any given orifice size, the functional severity of stenosis is going to be greater in eccentric jets, both because of greater pressure loss and also reduced pressure recovery time. Another concept to take into account is the Coanda effect. And this is basically the tendency of a stream of fluid to go around a convex surface rather than follow a straight line in its original direction. So this is like when you're pouring water from a pitcher, the fluid tends to run down the outside of the pitcher when you're trying to pour rather than go straight in. And then just to bring it back to the continuity equation, you can rearrange this equation to determine or calculate out a valve area. And so in this example, you're looking at your LVOT and your aortic valve. So A1 and V1 are going to be that the area and the velocity at the LVOT, whereas A2 and V2 are going to be at the area of the aortic valve. And by rearranging this, you can figure out what that area at the level of the aortic valve is. The ultrasound images shows you how to do that. You're going to do it in your peristernal long axis view, measuring the aortic valve area, and then your LVOT velocity time integral by pulse wave Doppler, and your aortic valve velocity time integral by continuous wave Doppler. So applying this to aortic stenosis, there have been guidelines put out by the major cardiology groups and the American and European cardiac imaging groups to recommend what hemodynamic parameters we use for aortic stenosis. And the three main ones are your peak transvalvular velocity, your mean transvalvular pressure gradient, which is obtained by the Bernoulli equation, and your valve area, which is what we just went over with the continuity equation. And these are guidelines. Again, these are going to be adult numbers, but they've come up with grading of mild, moderate, and severe based on these parameters. And then they have done the same thing for mitral stenosis, where the recommended hemodynamic parameters for measuring mitral stenosis are going to be your mitral valve area, your mean transvalvular pressure gradient, or the Bernoulli equation, and then your pulmonary artery systolic pressure. This is just a review of the limitations of these assessments. So again, with color flow, you can have turbulence or aliasing. With your jet velocity, you want to really make sure you're parallel with your interrogation of flow. These measurements are also flow dependent. So it's going to be increased in high output states or decreased in low flow states. And so that may overestimate or underestimate your severity. Mean gradient is also flow dependent. So again, if you have low flow, you might have a low gradient. If you have high flow, you might have a high gradient. And also non-parallel alignment is going to lead to underestimation. And then area by continuity, using the continuity equation, you're assuming a very circular geometry of the LVOT, which it may not always be. And you're also requiring parallel alignment of that interrogation. And then the flow across the regurgitant orifice. So using very similar concepts, we can use a continuity equation again here, where you're estimating regurgitant volumes by actually subtracting your stroke volume across one valve and your stroke volume across another. So the continuity equation is implying that the amount of blood flowing into the LV across your mitral valve is going to be equal to the amount of blood flow that goes out of the LV across your aortic valve. And so any difference in this antegrade flow is going to represent regurgitant flow. And so you can do this for both the mitral and aortic valve by rearranging this. We can also use color Doppler here for quantitative measures. This is known as your PISA, or your proximal isovelocity surface area. This is a phenomenon that occurs when liquid flows through a circular orifice. So flow through the orifice itself is going to be non-turbulent. You can directly calculate flow if you know your cross-sectional area. And then you can measure your PISA, your surface area. So this again uses the continuity equation because it's saying that flow across the area proximal to the orifice has to equal the flow through the orifice. You have a pattern of flow convergence that's proximal to the orifice that can be used to calculate the volume of flow across a surface proximal to the regurgitant orifice. And I will show you in the next slide just how to measure this. So for your circular orifice, you have this, you put color Doppler across, and you're aligning your transducer angle with the central axis of the flow into the regurgitant orifice. You're going to need to adjust your velocity scale or your Nyquist limit. And so you're basically trying to get that aliasing effect where your color changes. Your blue becomes red, your red becomes blue. And that's because you're trying to get a velocity greater than that Nyquist limit, because that's what you're going to measure. And then you measure the distance between the aliasing boundary and the flow orifice. And this represents the radius of that hemisphere. To calculate the surface area, it's 2 pi r squared. To get your regurgitant flow, you're going to multiply that by your aliasing velocity. In order to get your regurgitant orifice area, you can rearrange that equation so that you divide your regurgitant flow by your max velocity, and then your regurgitant volume is that area multiplied by your velocity time integral. I rarely ever use this, and I don't know how. I think it's probably impractical to use it in pediatric POCUS, but this is something that has come up with adult cardiac POCUS. And then aortic regurgitation, you can also look at pressure half-time to determine severity of aortic regurgitation. So you're going to place your your color flow Doppler over the LVOT and apical 5-chamber view. And you want to identify the regurgitant jet that comes back into the LV, and place continuous wave Doppler across that jet to measure the envelope from the peak to the end of that envelope. And if it's less than 200, that typically indicates severe aortic regurgitation. As I mentioned at the beginning, I'm not really going to go into systolic function because you do get 2 really comprehensive lectures on this. But I will just summarize that for LV systolic function in pediatrics, we tend to use fractional shortening and ejection fraction. In adults, they have other methods like the mitral annular plane systolic excursion and your E-point septal separation and fractional area change, but I don't think these are commonly done in pediatrics, and we don't really have normative values for them. And then for RV systolic function, we also don't have great quantitative measures in general, but some of the ones that have been proposed are fractional area change, TAPSE, or your TR jet. Again, these are prone to the same limitations that we've talked about for some of the other measurements. And then the last part of my talk is diastolic function. And I would say that in cardiology, just by echo, this is very complex and there's a lot of different measurements we can use. So I don't know how practical it is in POCUS, and especially in pediatrics where it is right now. But I know that there are a lot of studies out there in the adult literature in emergency and intensive care that is really trying to find some measurement of diastolic dysfunction that can be used, that can be done really quickly to assess this. So a review of diastole. You have 4 phases. You have isovolumetric relaxation, early diastolic filling, diastasis, and late diastolic filling. And at the top, you can see that you're trying to measure a Doppler signal at your mitral valve inflow. And the E wave corresponds with that early diastolic filling phase, and the A wave is going to correspond with your late diastolic filling phase or atrial contraction. The components of diastolic dysfunction include impaired LV relaxation, reduced restoring forces, or increased chamber stiffness. So basically, there's 2 main inputs of diastolic dysfunction. It's either that your ventricle is intrinsically dysfunction or has dysfunction, or your loading conditions in your atrium and ventricle are affecting that. Other factors that can influence diastolic dysfunction are age, heart rate, ventricular interdependence. So again, this is a complex measurement even within pediatric cardiology. But in 2016, the American and European imaging groups came out with new guidelines, really with the goal to try to simplify how we assess diastolic dysfunction by cardiac echo. And they came up with looking at 4 different measurements for diastolic dysfunction, and that's your E prime velocity, either the septal wall or the lateral wall. Again, this is of your mitral valve. The E to E prime ratio, the LA volume index, and your peak TR velocity. And I will go through what each of these measurements mean. There's also measures that we can do by echo with the deceleration time and the pulmonary vein inflow. And these are surrogates measures for compliance of the ventricle, where a shorter deceleration time of your E wave usually correlates with a stiffer ventricle or an increased LA pressure. but I'm not going to go into detail with those because I don't think that we really use those for POCUS. So as mentioned, the mitral valve inflow, your E wave correlates with early diastole, and your A wave correlates with atrial contraction. And so the things that can affect your E wave are going to be the pressure gradient between the left atrium and the left ventricle, and also LV compliance. The things that are going to affect your A wave are atrial contractility and, again, LV compliance. And the limitations of this are when you have arrhythmias, this is volume dependent. So again, what your loading conditions are on that ventricle, and then also age dependent. The mitral valve inflow in diastolic dysfunction can be rated then from normal to severe, and basically looking at this ratio of your E wave to your A wave, where normal is usually greater than 1. But keep in mind that you can have this pseudo-normal effect in moderate dysfunction, where after your EA ratio became less than 1, it can convert back to greater than 1, and that's because the ventricle is becoming less compliant and volume overload ensues. And so your LA pressure increases, which restores that gradient between the LA pressure and your LVEDP. And then, as I mentioned earlier, there's also tissue Doppler imaging that we can use. And this is where you're looking at your mitral valve and either the septal or lateral wall. Your E prime is going to, your E prime and your A prime correlate with the same measures as your E and your A wave. So your E velocity, E prime velocity, is a surrogate for the rate of myocardial relaxation, and is what is useful with the tissue Doppler is it's relatively independent of loading conditions. So your E over E prime estimates your LVEDP, and there are some normal values listed there. And the limitations of this is if you do have any mitral valve disease or pericardial disease, you can't really use these measurements with acute systolic heart failure, and then also if you have POCUS. And then just to review, diastolic dysfunction in cardiac POCUS and the literature, there have been many studies actually associating some of these parameters with an increase in mortality. One of them from 2016 showed that your E to A ratio, your E prime velocity, and your E to E prime ratio was most important in your 28-day mortality in septic ICU patients. Again, this is in adults. And so a lot of studies have really tried to see if there's a simpler parameter we can do by POCUS, and how that compares to doing a full echo for diastolic dysfunction. And so there have been a couple studies that have looked at using a simplified method versus a comprehensive method. And unfortunately, the reviews are mixed. So one study had for concordance and underestimated the severity of diastolic dysfunction. Another one overestimated that severity. And another one has shown some agreement between just using the average E prime method. So there's a lot of studies like this out there, but I don't think any have really been conclusive in what we can use for diastolic dysfunction. And that is really all I have. These are my references. So I don't know if there's anything else. If Eric is still on, if he has anything else to add in terms of POCUS and using quantitative measures.
And thanks so much. That was fantastic. From the standpoint of, I know there were some things that we're wondering if their utility in POCUS is well tested. Where I think we have some markers that indicate so is like you mentioned in the adult POCUS, some of the things like PISA approximation of mitral valve regurgitation volume is is described. For those of us who are taking the echo boards, and like there are more and more PEDS people are taking the adult echo boards, it's all over that. So
Mhm.
I think that's a that was a new skill some have had to learn when we had to do that. And for diastology, I it's really interesting. I know that there's tons of people who don't even know how to turn tissue Doppler on their machines, but the work by Lanspa, there was some retrospective work that's been done looking at diastolic dysfunction as well, in studies that were done both by through comprehensive echo and also by POCUS folks who have found that diastology tended to find markers that portended mortality more so than systolic markers did.
Mhm.
Um, yeah, I've talked with Mike Lanspa before, and also Sarah Ginsburg, who does some work on this, and both of them are like, I don't know how to get people into this, but the data seems to really speak to it. So I think that as we develop
Interesting.
things more, at least if people know how it's done, that I
Yeah.
think that's a step in kind of putting all the pieces together.
Yeah, great. Thank you for that.